Alrighty, good afternoon, everyone. My name is Dr. Dunn, and I will be moderating our session today for our panel. The title is Black Maternal Health and Policy Practices, Policy Perspectives. And I'm going to first start out with a video from Senator London Lamar, just to get us started.
Tennessee is in a maternal health crisis. In 2020, 98 women died due to pregnancy or within 1 year of giving birth, and more than 75% of those deaths were deemed preventable. To say that in another way, more than half the women who died from pregnancy issues in 2020 should be alive today. The leading cause of these deaths were substance abuse, mental health conditions, discrimination, and obesity. Furthermore, Black women like myself were 2.5 times more likely to die from pregnancy-related causes than white women in Tennessee. These numbers are also very real to me. I lost a child during pregnancy and also witnessed my cousin dying from pregnancy-related complications. I personally know all too well the pain and trauma associated with maternal health and the challenges associated with trying to give birth. It is vital that we focus on improving the support available for birthing people here in Tennessee. If we don't, more people will die, especially with abortion now being illegal in Tennessee. The legislation that I proposed in the 112th General Assembly reflects that goal. My doula resolution was the first step to ensuring that all pregnant people have access to life-saving care provided by doulas. Research shows that doula care reduces the risk of C-sections and other preventable complications, as well as other chronic conditions. This year, we took another step. I passed a bill that directs the Department of Health to study doula certification programs and present their findings to the General Assembly. The recommendations that come from this study could create a path to improve access to doula services in the communities most in need. I launched the first ever bipartisan maternal health caucus to convene state officials and craft legislation that would improve maternal health outcomes. In addition, I have passed and introduced legislation that extends Hope Scholarship eligibility for pregnant students, implicit bias training for doctors, and remote patient monitoring services. But there is more work to do, and I need your help to get it done. Basic human rights, including maternal health care rights, are being shifted back into the hands of the states. It's more important than ever to participate in your state elections this year. We have the state general election coming up in November. Know your candidate's stance on maternal health and what they plan to do to improve the outcomes here in Tennessee. After election, stay engaged with the legislature. Be on the lookout for bills that support pregnant people and expand their access to care. Reach out to your representatives and encourage them to vote in support of those pieces of legislation. Hold your representatives accountable when they don't champion healthy moms and babies. And last but certainly not least, find your local community organization who are on the ground doing this work and support them with your time and financial resources. There is so much work to do, y'all, and I know it can feel overwhelming at times, but know this, our fight continues today. We will not stop until every woman has the explicit right to shape their families, to access the health care they need, and decide when or whether they have children. I'm State Senator London Lamar, and I'm hoping to have your support around maternal health here in Tennessee.
Alrighty, so huge thank you to Senator London Lamar for those remarks to get us started. So for this panel, I'm going to go over the objectives first, and then I will introduce our amazing group of panelists. So first, our objectives are to share the opportunities and needs for Tennesseans to support bills that advance maternal health care for mothers of color in Tennessee. We're also going to be exploring and assessing the racial inequities and racial disparities that exist as it's related to maternal health in Tennessee. And last but not least, we'll also be learning about the different comprehensive care models that exist to support mothers of color in Tennessee and how to access them. So thank you for joining us today. I'm going to introduce the panelists. So first on our panel, of course, we had Senator London Lamar from Senate District 33 to start us out. We also have Dr. Cornelia Graves, who's the medical director of Tennessee Maternal Fetal Medicine and the medical director for perinatal services at St. Thomas Health Systems. She's also a professor at the University of Tennessee and clinical and adjunct professor for Vanderbilt University and Meharry Medical College. Next, we have Ms. Chemyeeka Tumblin, who's the owner of PositivelyMyeek. She's also a marriage and family therapist, currently under supervision, soon to test though. And lastly, we have Miajenell Peake from Peake Wellness. Each of our panelists will also give you an opportunity to tell you about themselves more in depth as well. So we're going to go ahead and get started. Some housekeeping. I will address the questions in the chat when the panel has completed. So feel free to put several questions in the chat. We're looking for a wonderful and dynamic dialogue for today. So feel free to put those in the chat. We'll also be taking questions from the audience at the conclusion of the panel. So this is what we're waiting for. I've got my first question for our panelists. Okay, so please tell us about the work you do as it's related to maternal health for women of color. And we.
Well, I'm Dr. Connie Graves, and I have been working in the field of maternal health for about 35 years. My interest in maternal health actually comes from my background as not only a obstetrician gynecologist, but a maternal fetal medicine specialist with a focus on critical care. And so I always tell people maternal mortality became an interest about 10 years ago. Maternal mortality has always been something that I have fought and worked for years. Currently in the state of Tennessee, the current Maternal Mortality Review Committee is a product of my work with Representative Harold Love and approaching him and making sure that we had an MMFT working to review all of the maternal deaths in the state. It's important for us to do that because then we're able to then segregate that data by race and get a better understanding of what's causing maternal deaths. Currently, I work with the CDC and the ACOG. We have been working on a new form to help abstractors with looking at maternal deaths to identify discrimination, racism, and bias as it relates to maternal death, so that we have a clearer picture of what is actually contributing to maternal, especially Black maternal mortality in this country.
Well, good afternoon, everyone. My name is Chemyeeka Tumblin. In relations to why I'm here today, I am a marriage and family therapist. So speaking to the mental health side of maternal health, the importance of the work or why that work is important. Specifically, when I started my training in public health alongside Maya, the program opened up a lot of doors for me, especially throughout my internship, to look at behavioral health and how that impacts not only our communities, our built environments, but our families as a whole. And what I noticed was that when we talk a lot about the programs and systematic structures in which our community, specifically those African American, are birthing, how does our mental impact play a bigger picture? So when these individuals are getting connected to services and having or creating families or even planning a family, who is there to talk them through what that family history looks like, what the trauma is that they endure, what is the trauma that the communities that they're a part of may be impacting or how they are impacting their day-to-day lives. We talk about, specifically social determinants of health, or the fact that a lot of individuals are impacted by PMAS. environment plays a huge role in those things. So as a therapist, I get to sit down and talk with individuals and walk them through resources that are available to them to not only be able to work on changing what their environment looks like. So whether that be housing resources, connecting them to services such as food and other resources, but also what is it that your parents did that maybe you don't want to do? What is it that your parents did that was a method of survival, and how are you thriving? And how do you then take those services and change them for your future? And not only that, being a doula myself and also sitting on different boards, being able to also bring that into the room and tell my clients like, hey, here's what a full service healthcare team looks like based on your history or based on the problems and the fears that you've already told me about. These are people that need to be a part of your team, not choosing it for them, but because of my knowledge, being able to open the door and say, hey, I'm not sure if anyone else is telling you, but I'm going to make sure you know you need to do it. You need a midwife. You need to make sure that you're in touch with the people at, if you already have children at their school so that they're getting the services they need. How do we decrease the stress load that is impacting you as you're not only trying to create a family, but also as you bring a new life into this world?
Hello, everyone. I do apologize for not being there physically. I'm actually in DC at the Black Mamas Matter conference. So I'm excited to talk more about maternal health in Tennessee. I'm from Tennessee, so I'm super excited and honored. So my name is Miajenell Peake. My pronouns are she, her, and hers, and I eat, sleep, and breathe birth. I had a wonderful experience with having my daughter, and ultimately I just opened up a business to ensure that Black women was receiving the care that I had. I had a Black midwife. I was able to have my daughter at home. And again, like that was basically the reason why I started my own business, Peake Wellness. Peake Wellness is a private doula agency where we basically make sure that women that are African American make informed decisions about the birth that they would like to have, whether that's at a hospital, home birth, or a birth center. I myself, I am a doula. I'm a placenta encapsulator. I am a nursing student with the goal of becoming a midwife. So with Peake Wellness, I've helped over 100 women give birth. And I like to say, doulas are somewhat of a non-biased person in the room. We're not tied to any hospitals or normally any birth centers. And we're really just making sure that the person has the birth that they ultimately want. Making informed decisions about medical interventions. We're educating individuals about the process during birth. We just don't show up at birth. A lot of individuals have all these misconceptions about giving birth, and rightfully so. They have a lot of fear around birth. We go through the process of unlearning and relearning about birth. And I love to see ultimately that pregnant women, go from fear to empowerment through the process. And yeah, it was just a great experience to see women go through that transition. And yeah, so that's ultimately why I built Peake Wellness. And again, it's at hospital, home births, and birth centers.
Awesome. Thank you so much to our panelists for introducing themselves and giving us much more in-depth information about the amazing work that they do. I heard so many different unique services like being a doula, research, placenta encapsulation, and birthing. And so that leads me into my next question for you all is, what is the unique service that you provide, or what's unique about it? And then how is it important for all women to have access to it?
So let's be real. Tennessee has some of the worst health of any state in the United States. We have high blood pressure, we have diabetes, we have heart disease. And what the senator did not say is that the leading cause of pregnancy-related death is none of those things. It's cardiac disease, followed by preeclampsia, followed by hemorrhage. So, while it's nice to have paid people who deal with when birth is low risk and uncomplicated, it is great to have people who can kind of deal with the birthing process and things. But so often, births for Black women aren't low risk and they're not uncomplicated. So having access to a maternal fetal medicine specialist, not someone who does high risk OB, because those can just be 4-year trained people who decide they want to put out a shingle. A maternal fetal medicine specialist is a fellowship trained person who has trained past their 4 years of OBGYN because we lost our mind. And so we decided we want to train for in my case, 7 years. In order to understand the physiology and in order to understand those complications of pregnancy, because when you know and understand those things, then you can then make preparations. I just delivered a patient Wednesday. The patient had heart disease. She had heart failure. So our plan of care for her had to include how to get her delivered safely, soundly, and how to make sure, and I believe, I was just texting with my cardiologist, we both believe she has a family issue that we need to work up genetically and making sure that she has long-term follow-up. So maternal fetal medicine services are extremely important for Black women, and it's extremely important for us to know the difference between someone who just does high risk or says they know how to take care of high risk and someone who is a fellowship trained board certified specialist.
Sure. That's a big act to follow. What I will say specifically, especially for speaking for the mental health side, and I thank you, Dr. Grace, for saying all those things, because when you think about that, specifically, 9% of women, specifically post-birth, suffer from PTSD. If I'm having hemorrhages, cardiac arrest, or feeling, so something that was not mentioned, which that Dr. Grace said that I think is definitely important to bring up here, racism. When you think about these things, how do you not have PTSD? How do you not have anxiety? How are you not having stress? Also, especially for African American women, what does the family structure look like? And when I say that, I'm not talking about the dynamic of who's in the family. I mean, what was the stories that were passed down to you on what motherhood was supposed to look like, on what pregnancy was supposed to look like? We just went through an entire pandemic that is not over. What does support systems look like for individuals who are giving birth? They aren't having, the whole family in the birth room if they're in the hospital. Even if they're at home, those older family members, the patriarch of your family, may not be present for that birth because of the risk of not only your health, but their health. So we're in a sense being cut off from things that at one point in time very much were the basis and the root of how we went through it, literally building a family. So the importance of that mental health structure there is so that you have someone to talk to, not only post-birth, but during birth, and also prior to birth, even when you're in the family building process, so that mentally you are able to walk through that process. Something that I did not say before is also that when we talk about the numbers of women that are dying, there's a dad, there's a grandma, there's a sister, a brother, there are families connected to those numbers. My specialty is dealing with grief and loss. I work with those families who have had a loss. A lot of the moms and the birthing people that I'm working with them through pregnancy, they've had a loss prior to that. Or they may be having a high-risk pregnancy and we're unsure if they're going to have a live birth. So specifically, the work that I'm doing is literally what I'm telling you in mental health, but then literally bringing a story to it, like reminding them this pregnancy is not your last pregnancy. How do we build faith and confidence in your body and also in your support system? How are we making sure that if you are a person of faith, that you are rooted and grounded in that faith, and how do we bring that into the room? And not only that, how do we talk to a community and talk even in rooms like this where we're constantly talking about the dire effects or the fact that disproportionately as African-American women, we are impacted by birth, and we already go through something called weathering. So as we age, our body already due to racism and those, microaggressions is aging far greater than our counterparts. Who's the person that's on our team that says, hey, and I'm going to talk about me. I talk about me a lot. HIPAA purposes, I have client stories, we're gonna talk about me. Chemyeeka, you tell this story a lot. Yes, you're in these rooms. Yes, you have your own medical story, but also you're gonna have another pregnancy. You have people, you work with these people who are gonna be a part of your team. You talk to them on a daily, you're gonna be okay. And we need that. So a mental health provider, yes, I'm not your friend. I'm someone there who's a champion with you and helping you to advocate for yourself. But I'm also that voice that, while giving you the realistic data, is also that voice of hope that says this does not have to be your end.
Absolutely. I totally agree. Like it just reminds me of like it's a lot of misconceptions around, doulas and who we serve and what we're about, as far as like sometimes people think that doulas are these very natural, and every doula is different, but I think one of the biggest things that I try to promote is doulas are truly birth experts, and one thing that we're very really good at is helping individuals navigate the healthcare system, like, and I think, having someone, that's pregnant, that is high risk, the doula knows who you should go to and who you probably shouldn't go to, right? I think that a lot of individuals think that doulas are there to break down the system or like make the conversation around birth or your provider very difficult. I think, what I try to promote is this collaborative approach, ensuring that individuals make informed decisions and the approach is patient centered, right? If you are high risk, you can still have a doula. If you are lower, even if you don't necessarily want to have a home birth or a water birth and all those things, majority of individuals don't even know what those things are. They're just wanting someone to hold their hand, talk to them, educate them through the process and see what is possible.
Nice. Wow, I heard a lot of great and amazing responses to that one question. And Dr. Graves, you said something that was just pivotal, was that there's a difference between, working with a doctor who works with individuals who are high, say, I'm a high risk doctor. I work with them at high risk, between being a board certified. That has just a different ring to it. It sits better on my spirit. If I was a woman, I'm like, okay, I can go see Dr. Graves because I know Dr. Graves will be like, I know what I'm talking about, right? And there's a lot of misconceptions that you all are breaking down, a lot of misconceptions and myths about the birthing process and about doulas that is great for women to have access to. What happens, and we've kind of touched on this just a minute ago, but what happens when women who need it most do not have access to this type of maternal health service? And there are so many different services, mental health, we talked about different things. So, what are some, what happens when we don't have access to these services?
Well, I would love to start. So specifically speaking, Maya spoke to the fact that oftentimes it's not talking about our specific roles. We are helping you to navigate how to build a team. So the team is what's important. When people don't have access to a team, sometimes you end up with individuals who are having to play multiple roles. Maybe in a sense, especially when we're talking about birth, you don't want burnout on your team. So you definitely want people who know their role, play their role well, and it's not stepping into another lane, especially when your life is what's on the line. Also, if I were to throw out some stats, literally 1 in 5 women worldwide experience PMADs or postpartum or perinatal mental health, anxiety and depression disorders. 20 to 25% of pregnancies worldwide end oftentimes in a miscarriage. So we're talking about individuals who they're going through the pregnancy process, whether it be the entire pregnancy or portions of the pregnancy, but not able to take home a live baby. And then we talk about things such as depression. What oftentimes get left off the table is the fact that if you've at any point been pregnant, you too are postpartum after the loss or giving live birth. So you have depression and grief from a loss along with that postpartum depression. So those services are definitely needed, because if you don't have a doula or if you don't have a Dr. Graves, you don't have a Maya, you don't have someone to tell you, not only do you need to speak with someone who understands grief and depression, you need to speak with someone who understands what postpartum looks like. So you need access to individuals who are in the room, who not only have specialties such as ours, but who look like you. The women who can tell you things that may differ from what your family is telling you. Not that your family is wrong, but also we too have those families. We know some of those stories that you're hearing, so we can tell you with a gentle hand, grandma and them is right, but also you may have to do this a little different. You may have to be the one in the family to try something different. That's not a bad thing. It's just we want to make sure that you're well, and on the other side of this, you're having the resources and the services that you need. Something else that Maya was saying, such as, of course, advocating and then making sure that you know what it is that you specifically need. Dr. Graves spoke to that as well in talking about a board certified physician. Also, someone who's not afraid to tell you when they aren't the person you need. Like, this service may be out of my scope. Or when we're looking at your team, if you want me to stay on the team, you need someone else who may do something similar to me, but this is how we differ. Someone who also is not afraid to talk about the finances. Like, okay, what does your team look like, and how can we get you the team that mirrors that and one that you can afford? So that's when it comes in to know what policy and other things look like. What does your healthcare insurance cover? Is it enough? Do we need to connect you to a health department or another service that can align you with services to get you better healthcare? Is there a service where, specifically in this phase that you're in, that you may be able to get because you are eligible for it now, but you weren't before, and being able to save them? Like, a lot of individuals who are pregnant don't know that you definitely need a dentist. You don't talk about what happens in the dental field when you're pregnant. Do you have a great person to talk to who may be the person that does your hair? Because we also don't talk about what does it look like to lose your hair? What does it look like to maybe have literally the texture of your hair change because of a pregnancy? And if we're talking about the family building process and taking it back, for individuals that may have PCOS or endometriosis, what does the hormone changes look like? What does your doctor already need to be telling you? Because before you even get pregnant, these are barriers that we already know you're going to have to face. And how do we help you come across those? And so I'm gonna stop now because I can continue, but I know my fellows have other things to add to that.
You want to go, Doctor? Yeah.
Well, I think one of the things that people have to realize is when you don't have access to certain services, you may not have a great outcome. Because they're, number one, and it's not just the doctor or the midwife or the nurse practitioner who sees you. It is also the hospital that you elect to deliver in. Not all hospitals are created equal. Yes, they have a great bathrobe, and you thought that would be something you should take home. And before HIPAA, you could put signs in the yard. But that's not what you're looking for. What you're looking for is you're looking for whether or not your hospital has experience, especially if you have high-risk medical problems, in taking care of those. What type of team do they have? If you have heart problems, do they have a cardiac obstetrics team that works with you? Or do they just have, is it going to be something that just thrown together? When you're choosing a provider, we're maternal fetal medicine specialists, and so we don't interfere with your doula nor your OBGYN. We don't take over your care, but we're consultants that provide advice back to your team. Fortunately for us, I have mental health in my office. So, when I have somebody who's on opiates or any of those people who need support, or patients who need support postpartum, or those pre-eclamptics who thought they were going to have a home delivery, but then their blood pressure was 160/110 at 32 weeks, and they were told they had to come to the hospital immediately. And now they have post-traumatic stress syndrome because it just wasn't what they expected. We have those services available. So it's important to know that when you don't have these services available, your outcome may not be great. The other thing you should know is what type of postpartum support does your hospital have? Do they have a lactation program? Do you have to come in for it? Is it available by telehealth? It is great to deliver where your friend delivered because they thought they had a great experience, but you also need to know experience has, especially in an emergency, what you want in a hospital who has experience in doing a lot of emergencies, and not something that all of a sudden they're like, oh, this is the first one we've seen, because that is not going to result in a good outcome. So that's what happens when those services aren't available.
Thank you.
Absolutely. I want to piggyback off of Dr. Graves, like about the Medicaid. London Lamar mentioned, Medicaid reimbursement. I think it sounds wonderful. I think it is a great way to increase access. However, similar to what Dr. Graves said, that a lot of people don't take Medicaid. So that in itself doesn't necessarily increase its access. Why do a lot of physicians or hospitals don't take Medicaid? Because Medicaid doesn't pay. So we have to create the entire structure completely different to increase access to whether it's a home birth, hospital birth, the doula. It sounds great, but we definitely have to increase access on a whole nother level because, and I'm talking about Memphis, Tennessee. If you do have Medicaid, you only have one hospital to go to. You can't go to the fancy, hospital that has low C-section rates, right? That's only accessible to a certain population. So that in itself has to be changed. I also think that we need to get ahead of education. We need to talk about reproductive health in schools. A lot of the individuals that I work with, they only think about pregnancy when they are pregnant. They're only talking about nutrition and eating or drinking water when they're pregnant. We are behind the 8 ball when we talk about nutrition when you're pregnant, because when you're pregnant, everything is heightened. So maybe you had, you were tittering, you had a 120 over 80 blood pressure when you weren't pregnant. Now it's 140, one is 160. But, all these things are kind of increased when you are pregnant. So I would argue that we need to talk about pregnancy now that abortion's banned, right? In Tennessee, this is a great opportunity to talk about pregnancy in the schools, right? It doesn't necessarily mean that we're promoting sexual activity, but we're prepping our community because we know that majority of people that have uteruses, they will become pregnant. Why not talk about pregnancy way before they're even menstruating? So I think it definitely needs to be like we need to talk about preconception health. I would argue even in elementary.
Wow, that you guys are sending some chills down my spine because some of this is like really resonating, and I really appreciate these responses because death is finite. And cardiac arrest, like the outcomes that can come of that when we, if we survive that, the ramifications though can still be so harmful on the body. The education is key, and I like that, Maya, that you added that in there. I appreciate that.
And me and Chemyeeka, we definitely have public health degrees. We're all about prevention. We talk about tertiary and all these things, cardiac, these are all diseases that could be course corrected if we get it in advance. You don't see cardiac disease when people are 5 years old, right? Majority of the time. Correct me if I'm wrong, doctor, but at the end of the day, people talk about these things before, and I laugh and kiki a lot. I was like, 15 years of eating hot Cheetos and Kool-Aid is a long, and you want a home birth, right? But you don't drink water. It's very hard for me to course correct that in 6 or 7 months, to be honest. So it is a little accountability that we have to take when it comes to educating our community.
Right.
I would love to add to that too, especially when Maya broke down the hot Cheetos and water piece. Like, also we talk about we want to decrease stress. We tell a lot of new parents or anybody who's in family doing decrease your stress. We in a whole recession. the penny happened, and then also we're talking about communities where often people are working multiple jobs just to survive. How can I decrease stress? I gotta eat. How can I decrease stress? I gotta pay tithes. How can I decrease stress? I need gas. Like, you're telling me what I need to do looking at my circumstance, but you're not offering me a way to do that and still make sure that I'm gonna be okay.
Mm-hmm.
Well, I would say that yes, you can have cardiac disease when you're 5 if you're born with it. But again, for women of childbearing age, for who will be childbearers, that is an opportunity to begin to educate about contraception and birth planning, because you don't want to get pregnant with your diabetes, or with your heart problems, or with any of those types of things without understanding what those consequences will be. And of course, when, I laughed when she said promoting sex. No one has to promote sex. It is a natural nature thing that happens. And so when teenagers become, and come into themselves, or as my grandmother used to say, begin to smell themselves and do things that are, or they do things that they really may not may not be thinking about the consequences, then we end up with issues that we have to deal with. Now we have a young lady who is was born with a heart problem, who is now pregnant in the state of Tennessee, and unless I think she has a greater than 50% chance of dying, I now have to continue that pregnancy for her. And on top of that, that heart problem may be genetic, and she can pass that on to her offspring. So it's important for us to have these conversations early, especially so that young women will know what those risks will be.
I wanted to uplift Tammy Camper's comment in the chat because it kind of goes along with what we're talking about now. And Tammy said, I believe Dr. Graves said the majority of deaths are from cardiac problems. Do you think that this is because the cardiac condition was not diagnosed or because it was not managed appropriately?
Oh, great question. Both. So we know that from data that about 60% of cardiac disease is undiagnosed. Currently, I'm working with the University of California, Irvine on a cardiovascular screening tool in pregnancy. Why is it undiagnosed? Because pregnant women are short of breath. Pregnant women have swelling in their feet. Pregnant women say they're tired. Pregnant women's heart rates are high. And unless you really pay attention, it's easy to say, oh, that's because that's due to pregnancy. I recently wrote a paper with my co-collaborator, Dr. Stacey Davis, who is part of our cardio-obstetrics program at Ascension St. Thomas. And when you look at the data, only about when someone is training in cardiology, their experience with pregnancy, they've seen 0 to 1 patients. Their whole training. So yes, so when they get a pregnant woman or a birthing person, and the physiology is so completely different, they may not know how to manage it. And of course, in America, we're very, what I call fetal focused. So everybody wants to know what's going to happen to the baby if I give this medication. And I always tell people there are like 10 medications you cannot take in pregnancy. I can count them on, hold up my 2 hands. If you need them, then you can use them. But because we're so focused, then we may take people off their medications or not start appropriate medications or give wrong advice, because especially if you don't see the right person, because the focus is much more on making sure the baby's okay than making sure that the mother-baby unit is okay.
And that's great, y'all. Some of these, whew. All right. Next question here that I have for you all. What are the biggest access barriers that you have seen in your experience?
So I kind of want to speak from, it's both sides of it, from the public health training, doula, as well as mental health. A lot of care in the African American community, like care in general, has stigma. There's stigma around seeing doctors. There's stigma around when and how you should get pregnant. There's stigma around mental health, what those conversations look like. So the stigma itself is a huge barrier because individuals also, while there is a lack of access to those services, there's a point where individuals also aren't seeking those services because of the stigma that comes with actually saying, I need help. And when we think about, you mentioned picking a great hospital. If I'm afraid to even see a doctor, how do I have to get to you to have a conversation around making sure I chose the right hospital? I didn't want to be at the hospital to begin with. If I can't talk about the fact that I want to have a baby, or I can't openly talk about sex, how do I get to a Maya to talk about what a doula does and the fact that I want somebody to hold my hand who may or may not be my parents or my significant other, or maybe I need someone in conjunction to them. When it comes to me, if individuals are taught motherhood is something once you have a baby, it just, you know what to do. Ain't no book gonna teach you. Once you have a baby, They put them on your chest, it's a feeling, it connects. All right, you know what to do, go home and handle business. You know, if you need to call me, hey, mama, how do I? Baby, I know they told you about that breastfeeding thing. I may or may not get that, so I'm gonna tell you, put that powder in that bottle, shake it up, and call it a day. You know, stop crying. You know, like, how do we have these conversations when on the other end of it, we were raised that they weren't, that's not a part of life. These things happen, you understand it, grandma did it, mama did it, you're gonna be able to do it too. So the stigma, and even, I think part of it was we had to overcome that stigma and that barrier ourselves to even be in the positions that we're in to seek out becoming that. A part of my public health program, I was learning a lot of the quote unquote folklore and stories that I was hearing about why my, grandparents and great grandparents weren't seeing the doctor. Wasn't folklore at all. That was their way of telling us what hospitals and other institutions of healthcare had done to them. It wasn't a lie. They were harming us. It's just how the story was being told was then being flipped to us, and we go on to, get education, that you got to educate your people because they don't understand it. No, they do. So now my job is to champion the story and understand, how do I take what has happened in my communities and also say how we're a part of the solution? How do I increase health literacy? Because as you were talking about, the situation with cardiac problems, if I don't understand what it is my doctors are telling me, or don't understand my family history, how would I understand the genetic outcome of my child because I have cardiac problems and I'm giving birth to them? How would I know what that does to me in birth? Maya's talking about healthcare access in Medicaid and the importance of her being able to help her clients navigate that. If I don't understand what healthcare insurance is outside of me showing someone a card when I enter an emergency room, how do I understand the importance of knowing being fully covered and being underserved?
Yeah.
And I think in Tennessee, you really have to advocate for policy that covers women earlier. Now, you can get, any woman in Tennessee can get coverage once they determine that they're pregnant. But there is not very good coverage and little or no coverage for women, whether you have Medicaid and sometimes even commercial these days, if you are for preconception counseling. We do preconception counseling, 9 nurse practitioners do it via telehealth. But but that's because we can bill for it in a certain way, but we don't use the word preconception counseling. We use other words like hypertension and diabetes and things of that nature, because a lot of companies still won't pay for even preconception counseling. And then I take care of women post-birth. I have a postpartum preeclampsia clinic, so we can talk about what preeclampsia means, your lifelong risk of hypertension, your lifelong risk of diabetes, your lifelong risk of heart disease. And the thing is that I can do that for a year. And then after that, if you don't have insurance, you have no other follow-up unless you have a chronic disease. So those are the issues with access for our patients. The other thing is driving. We have offices in Mount Juliet, Murfreesboro, and Franklin. But a lot of my patients in Franklin, Murfreesboro, and Mount Juliet still drive another hour to come in just to those places, or an hour and a half. And that means an hour and a half there and an hour and a half back. So they have to pick off at least a half a day of work and usually a full day of work. And last but not least, insurance policies that make absolutely no sense. For example, iron infusions. Iron infusion, like correcting anemia, is one of those things that can eliminate disparities in maternal outcomes, almost like that. Iron is relatively cheap, but you would think you're asking for gold when you're asking them to give you some iron. And then when I said, well, I like to use this iron that the patient has 2 visits, one of the MCOs had the nerve to say, well, what else is she doing? Well, my patient with 10 Care works the job. And I don't know about you, I own my own business, but I can tell you, I don't have 1 hour is in my day to get off to come back for infusions. And it's not really 1 hour because I have to get off 2 because I have to be able to drive there and drive back. So it is important for us to advocate for things that make sense, not just getting access, but making the access make sense. Why is it that we make 10 Care people keep on coming back and forth? When they have less transportation than other people, we have to make our payers and our people who insure our people make it make sense.
Yeah, I agree totally with both of you all. As a doula, it's a lot of barriers when it comes to accessing a doula. Every doula is different, however, I think it's a lot of misconceptions about what a doula is and how can we support. I jokingly say, like, I had one client mother called me a witch, all these things, it's just like folklore around what we stand for. But I like to say, we're birth best friends. We're there to support the mom. It doesn't matter what she wants. And also it's a lot of misconceptions between, the tension, whether it is true attention between a physician, and possibly a doula, before even sometimes meeting me, a lot of physicians, OBs, they say things like, we don't work with doulas or things like that, because maybe they've had bad experiences with a doula coming in and possibly, you know, advising the person on ill information about what is possible and all those things. Those doulas do exist, but I encourage a lot of like clinical providers to have a listening ear, when it comes to trying something different. I have an incredible relationship with MDs, advanced nurses, midwives, nurse midwives, certified professional midwives, and all of them understand we have the common goal of making sure that that person comes to the other side, when it comes to reducing harm, any traumatic issues. I'm at this conference and I'm hearing so much information around just a radical experience that people just have a listening ear to different ways of doing things, and this is an incredible time to really just bring in everyone and try things differently. I like to say a lot of nurses or even a lot of MDs haven't seen a physiological birth, without medication. I've seen it in all realms, right? But I also know that I'm not a clinical provider. I want individuals to make informed decisions. They should know what the pros and cons with every medicine, right? Sometimes we don't necessarily we need to do things by the book, right? Because this is how we got here, you know? So I think it's education on both sides. Of course, like payment, I am a private doula, right? Most of my clients do pay out of pocket. I do a lot of services, to make sure that I am accessible to that person that cannot afford services, but it's work to be done. If doulas are this critical piece when it comes to decreasing Black maternal health, it should be accessible, it should be affordable. So it is that huge barrier. I myself am working to become a nonprofit 501c3 where I can help that person not pay anything, so it's a lot of barriers to increasing access to doulas, and I think I just named 3. But I do have to go. I do have another conference, a presentation. I'm extremely honored to create space with you all to talk about this wonderful work.
Can you tell us where we can find her?
Yeah. Can you tell us your information where guests can find you?
Yes. So my website is Peake Wellness of Memphis.com. My Instagram is peakwellness_TN. And yes, that's where you can find me.
Thank you so much, Maya, for joining us. It's been amazing having you today.
Thank you. And you all stay blessed. Bye-bye.
So our last question to wrap up here, before we open it up for questions, for our panelists is, what do you think about the biggest what do you think are the biggest opportunities to expand access to care for women in Tennessee?
Full expansion of Medicaid. That is, because we have not expanded Medicaid fully. A lot of our rural hospitals have had to close. Well, if you are, and that then puts pressure on the emergency rooms to be able to understand and do obstetrical emergencies. This summer, our perinatal quality collaborative worked with our EMS staff to try to educate, because so many women live in maternity care deserts. And in fact, if you look at the maternal vulnerability index of the state of Tennessee, only Williamson County is safe. And so it is important for us to continue to push for full Medicaid expansion. And I think we have to change our narrative because, you know, the narrative has always been, well, they're getting something. But no, we're not getting anything. Most people in Tennessee need this type of coverage in order to have appropriate healthcare access.
The only thing I can add to that is yes, and the fact that it does open doors for even other services. Like you're not just talking about the access that someone has to a hospital, but access, as Maya stated, there are bills out there for those being able to take Medicaid. Mental health services being able to take Medicaid. Once it becomes expensive, we then can begin to lobby or continue to lobby, because a lot of us are already doing so, for services such as ours to be covered, for us to get paneled, so that we can provide services under, you know, with access being granted to those individuals who may not be able to afford the service without payment. And then also looking at the fact that if and when, hopefully it happens sooner than later, I'm not gonna say in my lifetime, we're gonna say sooner than later. Also looking at how does that then increase access to create greater birthing outcomes, starting with preconception. Maybe a little biased, that was a role I played at the health department before leaving, and also sitting on the Beamer infant mortality review team now. Preconception plays a huge role in this thing, especially now that abortion is banned. How are we preparing families for what birth truly is? And for those families who now already know that oftentimes it's not just having sex and creating a baby, there's work that is done. How are we setting them up for success? Because the way the government often states it makes it seem that the baby is success. I want to challenge that by saying the healthy family is a success. It's having the baby, but also having people who can support that child and having a healthy upbringing. It's having the baby and the mom not having PTSD because throughout the birthing process, she felt like she may die or her life was often at risk because the healthcare providers were not listening to her. It's having the baby, and the story before the baby even came into the picture is also one that makes after having the baby an even more, you know, propelling picture that says, yes, I had that child because of the process that I went through to have that child. I would have more. Or even if I decide not to have more, it's not out of fear. It's because the experience was so great. This is what we want to go.
Thank you so much for those responses. This concludes the questions that we had for the panel. I'm going to now go ahead and open it up to questions from our audience, both virtually and in person.
I have one question. How do we prepare women who know that there's a pre-existing condition, say fibroids, that runs hereditary through their family? And particularly at 29 years old, she has two older cousins that absolutely have not been children, and she has fibroids. So what is what direction should I lead her as far as preparing? Well, she's single, and she was told not to have them until she's ready to have them.
Well, I think that's a really good question. Just like I said, there are board certified maternal fetal medicine specialists who specialize in high risk obstetrics. There are board certified reproductive endocrinology specialists who specialize in getting women pregnant. So she needs to then talk to one of them and to determine the best course of action. It may be that they do not want to happen until she's ready to think about childbearing, is because they can often come back and then the uterus may not be able to be saved and things of that nature. But it's important to seek out those specialists, and her obstetrician gynecologist should know when this is out of their scope of practice. And people can always ask to see a specialist as well. You know, they say, I'd like a second opinion. And I always tell people, if your doctor won't let you have a second opinion, then you probably need to find a brand new doctor.
I think along with that, there are mental health providers that do reproductive mental health. That's a certification that I also have. And being able to have someone on your team who is there to walk through with you the joy in the not so, joyful news that comes with walking through the process of knowing you have fibroids or any PCOS or anything like that as you are navigating the journey that's going to create a family. In her situation, before you even get to the point of maybe thinking like, I want a partner, and this is what I want to do, to be able to talk through what is it right now? What is it like for you right now? To be able to talk through and maybe ask hard questions that she hasn't done so already. Like, some of your family history, but what are maybe some other questions that you haven't asked that need to be asked? If the outcome is not that you're going to have a baby, are you okay with that? Are you ready for that? And then what are your other options? And oftentimes we think about medical providers with those conversations, but sometimes those conversations happen outside of a doctor's office before they happen in a doctor's office. Someone who can help you build the courage to not only know how you feel about that, and that is okay, however you feel about that, but also the courage to actually talk with that medical provider about how you are actually feeling about whatever it is that you're telling you. And also to know that as a full spectrum doula, there are individuals such as doulas who can be with you in that process as you're going through that that side of healthcare, to help once again with the health literacy portion, help you advocate and ask those hard questions, and making sure that when news is being given to you, you understand what is being told of you and what it is that's within your control and what is not.
Thank you. Any other questions that we have?
I had a question about, I know you all mentioned preconception health, and I appreciate that, as well as mental health, and Medicaid expansion, right? There are so many things that need to be done to invest truly in Black maternal health to actually correct this issue of maternal mortality and infancy. But I'm wondering, what are some of those things that folks don't think about that you think are actually life-saving things for Black women? Like if every Black woman had access to maybe a doula care, but what would that thing be that you would say would be the number one investment that you would like to see to correct this issue of maternal mortality and infancy?
I'm gonna be biased and say if I gotta choose one, I'm gonna say therapy. And I'm a therapist with a therapist. So not just from the impact that it has on my clients, but the impact it has on my life. Because I am in the preconception phase. So what therapy has done for me to be able to talk through the things that I've seen. And in all honesty, like I said, you oftentimes talk about your doctor beforehand. I've been able to work through some things on family history with my therapist and then go to my doctor and say, okay, here's what I need you to know, because I think when we were meeting before, I was telling you this and maybe you were hearing this, but this is actually what is happening. Or be able to process what family stories have been told to me with someone and then go back and ask. And this is very oversimplified, but okay, all these people got sugar, but we're talking about diabetes. And so when we said this person died because, maybe they had a limb amputated and couldn't recover, or this, organ went into failure, those are symptoms of diabetes. So how do we then change that conversation for the family? So to say it not only is something that having access to that changes the course of life for you and your immediate family, but it can also change the course of life for everyone, because you're gaining knowledge and language to then take that to the people who actually, gave you the foundation that you have and the knowledge that you have for right now. And in the postpartum period, if you are already familiar with using that service, no matter the birth outcome, you know that as a resource and a support system that you can utilize and trust.
I just feel like y'all spoke all truth, right? Especially about the stigma, I think, especially for younger women, and being that there's so much stigma that just comes with our upbringing as it relates to pregnancy, right? It's dually scary when you have a healthcare system that might not treat you the best, right? So thank you.
But that's why you need a voice.
Right.
That's why you need a voice. That you can't have a voice through the advocate who has a voice for you. The CDC came out with their Hear Her campaign. We know that most maternal deaths occur because the voice. And you just have to keep on saying it over and over. And if you must, you need to be able to escalate that. You know, I hear you, but I'm not really satisfied with that. I had a patient once and she was told that she didn't like the plan, she could leave. But this patient had a stroke with previous preeclampsia. So she asked for another provider in the hospital. She fired the people that were seeing her and asked for another provider. You must have a voice and you must advocate. And you must advocate for yourself if you can't have someone who can help you with that. Because if you speak, eventually someone will listen.
I know all the 15, so I believe it.
I'm working with 6 rural counties in West Tennessee. This platform has been so, informative for me because you're talking about women that have more access to things that are going on. And I'm going to deal with, my focus is vaccine, but still, the conversation is the conversation. So they start talking about pregnancies, healthcare, and the young daughters, or even middle-aged women. I need to say, I have several people that I've listened to a panel with, and that from their contacts and their businesses, this is where we get the information from.
Even with the COVID vaccine, I think it's so important because people are going to tell you, well, I didn't take the COVID vaccine because, it not hurt, it will hurt my pregnancy. And you have to know, say no, you make messenger RNA every day. And so therefore, the only difference between the COVID vaccine and the flu vaccine is that when you get the flu vaccine, you get the virus. And when you get the messenger RNA, you don't. When you get the flu vaccine, the virus makes messenger RNA. So basically I tell people the COVID vaccine just cuts out a step. And so that's how I talk to them about it. And they're like, oh, so I'm going to make messenger RNA anyway. Yes. So if messenger RNA was going to mess up, people getting pregnant, we'd have that problem a long time ago.
I think something I want to add to the voice piece too. I've had the opportunity to work and continue to work with I guess you could call it tech. We talk a lot about how Chemyeeka came out with the Earth app for those of you who've already had a baby, and it's like for hospitals to talk about their safety. Like, is this a safe birthing hospital? There's also an app now called Health and Her View, which is like heard, understood, and experiences. And it's built off of the data that has come out that says that we have better health outcomes when we are connected to physicians, care providers that look like us. And not all Black people are monolith. Black people know that, but sometimes people who aren't Black don't know that. People of color are not monolith. And so in this app, you literally are able to put in where you're from. So if you're in a rural area, put in where you're from and see the physicians in that area that look like you. So it's an app of physicians and care providers of color, from doulas, therapists, doctors, and all. And then they also have healthcare resources such as, articles that you can look at, podcasts and different things, all geared towards women and birthing people of color.
Thank you. Can you spell those 2 resources that you mentioned, Earth and NRV?
Health and Her View.
But we spell the Earth.
Oh yeah, IRTH. And then Health and Her View is HEALTH, and then INHER, and then HUE.
All right. Okay, well, this has been an amazing panel, and I just want to thank our panelists, Dr. Graves, Maya, Chemyeeka, and also Senator Lamar for just being here today and sharing their wisdom and just being so inspiring. It's been a great panel, and I appreciate it. For the participants, is there a way to find you? Is there some information you can share before we conclude?
Yes, you can find me on Instagram at PositivelyMyeek, PositivelyMyeek. If somebody could type that in chat, because I know that was like kind of and then just find my name, Chemyeeka on LinkedIn, or any other stage. Particularly not on Facebook, but you can also find me there.
And it looks like we're going to add that to the chat there. And Dr. Graves?
Well, you can't find me on Facebook. You might be Cornelia Graves. Although I try to keep that as a non-professional, area. And you can email me at cgraves@tn.com.
Awesome.
Yes, I should add my email. It's just Tumblin at PositivelyMyeek.
And we'll make sure all the participants get that information from for everyone actually. Thank you all for attending. It's been great. I won't stop. I will allow for the chat to get those messages in there, but thank you so much for attending and be sure to fill out your evaluations. Thank you.
Bye-bye.